We all need energy in our bodies. This energy comes in the form of glucose. It drives various processes in the body and keeps us alive. The serum glucose can be checked by two ways. One way involves checking the glucose after a patient has fasted for at least 8 hours. This is referred to as the fasting blood sugar, or FBS. According to the World Health Organization, the normal FBS is between 3.9 to 5.6 millimoles per liter. The second way of measuring blood glucose does not take into account whether an individual has eaten or not. This is called random blood sugar, or RBS. The normal RBS ranges from 3.9 to 7.8 millimoles per liter. Hypoglycemia is defined as a serum glucose concentration less than 3 millimoles per liter. This threshold value is, however, not static. In children, hypoglycemia is a glucose concentration less than 2.6 millimoles per liter, whilst in other hospitals and ICUs, they often consider a value that is less than 3.5 and sometimes 4 millimoles per liter as hypoglycemia, whether with or without symptoms. Triggers of hypoglycemia include increase in insulin administration or release, increase in activity, reduction in food intake, infections, and alcohol, including up to 24 hours after drinking. Hypoglycemia may be a side effect of diabetes treatment, such as insulin and sulfonylureas, and not the disease itself. Other causes of hypoglycemia in adults include Addison's disease, insulinomas, and autoimmune hypoglycemia, where they are insulin receptor autoantibodies. It is important to remember that hypoglycemia is often considered severe if the patient requires assistance to replace the glucose. Clinical features often occur rapidly within a few minutes and can be as a result of autonomic response where an individual shakes, has palpitations, appears nervous, and feels hungry. In some cases, individuals may have features of neuroglycopenia, which include tingling, numbness, fatigue, drowsiness, confusion, coma, seizures, and ultimately death. This is a very common occurrence, especially in those taking excessive amounts of alcohol without eating. In some cases, hypoglycemia may be asymptomatic. Management of hypoglycemia depends on the clinical scenario present. If the individual is oriented, we encourage them to eat or drink 10 to 20 grams of glucose quickly, followed by slower release carbs once their glucose levels are above 4. If they are confused and are able to swallow, 2 tubes of glucogel can be squeezed into their mouth. In our setup, crystals of sucrose or sugar can be placed underneath their tongue. This treatment is ineffective if the patient is unconscious. In unconscious patients, glucagon 1 mg intramuscular or subcutaneously can be given. This can be administered at home, whilst in the hospital setup, we can give IV glucose in the form of dextrose 50% in adults and 10% in children. In adults, they may need 30 to 50 ml of dextrose 50%, whilst in neonates, they may require 2 to 3 ml per kg, and in older children, they may require 5 ml per kg. It is important to place them on some form of maintenance glucose-containing fluid after to prevent rebound hypoglycemia. In all instances, make sure to determine and treat the underlying cause because hypoglycemia, if left untreated, is deadly.